Very good evening to all of you. On behalf of my esteemed panelists, I would like to my gratitude to the ISSBT and the Dr. Sides and the whole team for inviting us for this meeting. I am really privileged to be here for the first time of the holy city of Nasik. So we have been asked to discuss about perioperative clearing of patients of surgery. So why a hematologist will be consulted in pre or post surgery? So if anything, patient have a cytopenias, maybe anemia or thrombocytopenias, or patient may be cytosis, like maybe counts are high, especially thrombocytosis, especially post-plenectomy thrombocytosis. If you have a good history taking residents, maybe you can have a past history or family history of bleeding, then they may call you as a hematologist to look into it before surgeries. Of course, most common is deranged coagulation profile, as we discussed in previously, prolonged PT or APTT on routine investigations. Sometimes we have known hematologic conditions but no complaint, but they plan for surgery like a thalassemia or a leukemia or ITP previously, they may ask hematology consultations. But one of the most important consultations normally we see is patients with oral coagulants and antiplatelet drugs if plan for surgery. So one of the most common is thrombocytopenia that do most of the studies in from our institute. Also this article from PGI also show thrombocytopenia is most of the commonest hematology consultation we see, out of which 1/3 are usually thrombocytopenia or immune thrombocytopenia purpura. So we have a varied clinical experts, so we'll try to discuss. It's difficult to discuss all, so we maybe try to discuss 3 case studies, focusing on thrombocytopenias and its thresholds for surgeries, anticoagulation and antiplatelet, either it breach or not to breach with low molecular heparins, or last part maybe sickle cell. I thought sickle cell is common here, so that's the reason I thought I have a sickle cell here to see the sickle cell how to manage that part. So it is the case 1, the 16-year-old girl presented to emergency with complaints of petechiae spots and menorrhagia for just 2 days duration, no history of any fever and drug intake. On examination, except few petechial spots, no organomegaly, no lymphadenopathies, most of the examination finds are normal. CBC showing hemoglobin 10 gram per deciliters, WBC normal, and platelets showing just 5,000 per cubic millimeters. Peripheral smear showing microcytic hypochromic. So a suspicion of diagnosis was diagnosis was made as newly diagnosed by ITP and treated with IVIG followed by steroids. She responded well, therapy, and platelets counts improved to more than 150, 1,70,000, and discharged with low prednisolone tapering dose. But presented after 3 months of prednisolone with an acute abdomen and suspecting an hemoperitoneume. So surgeons, they have suspected maybe plan for a laparotomy. Our CBC showing hemoglobin 8.7 and platelets showing 22,000. So with this background, the questions to Dr. Nilesh, does she need further treatment for the ITP now prior to surgeries? And if, then what do you think is the safe platelet count for a surgery in general and for this patient, and what should be the platelet threshold for various surgeries? Dr. Nilesh. Your mic is not on. No. I think there is a switch there. Just switch on this.
She will definitely need a treatment for ITP before surgery. We'll have to improve her platelet count before she can go ahead with that major surgery. And the safe platelet count for her surgery would be around, I would say, 50 to 80,000, as this is a major laparotomy surgery, and for that I would urge to start something which is going to act faster, like IVIG, and she had a response to IVIG in past, so I would go ahead with IVIG. If she's not affordable, high dose methylprednisolone can be tried. And for various surgeries, major surgery, neurosurgery, you need a platelet count of around 80,000 to 1 lakh before we can go ahead with a major surgery. And for minor surgeries, the platelet count of 20 to 50,000 is adequate. And for intrathecal or CSF, elective CSF, you should have at least 50,000 platelet count.
Okay, I think I understand. That's fine. Excellent. But normally, if a patient present with ITP, normally if it's no bleedings, if less than 30, normally you treat these patients with steroids. But whenever there is a major surgery, we need to reassess and treat these patients accordingly. So coming again to Dr. Nilesh, so if you have said to start treatment in these patients, what are the common options apart from IVIG in this group of patients, if you treat?
Okay. So for improving a platelet count on rapid basis, we have two options. One is IVIG, which can be given as 1 gram per kg for a day or two. And a second option is methylprednisolone, 30 milligram per kg per day we can start. And with IVIG, the platelet count will start increasing after 24 to 48 hours of giving IVIG. While with methylprednisolone, it will take around 72 to 96 hours for platelet to rise. So we can give that. Along with it, we can give platelet transfusion also if there is a life-threatening condition is there and you need to operate that patient. You can definitely, along with IVIG and methylprednisolone, give SDP and take that patient for surgery.
Okay, so that's fine. So any point, any
Sir, I would like to add one thing. If it is an emergency laparotomy, then we don't get time with IVIG and all this methylprednisolone. So why not go for SDPs and RDPs and take the patient, and for further, like for post-operative thrombocytopenia, we should think of giving IVIG.
Okay, so IVIG, normally you do feel to IVIG is the treatment of choice, but most of the times because of the cost, we most usually try to give maybe methylprednisolone high dose in this group of patients. Sometimes with a chronic ITP, you can give DEXA depending upon that. So at least steroid and IVIG, two other options we have. Do you have any experience on anti-D in this group of patients or before surgery, Dr. Nilesh, before going to others?
Sir, I have used anti-D not for the surgical patient but for HIV-related immune thrombocytopenia. I have used in 1 or 2 patients, but before surgery I have not used it, sir. Thank you.
Okay. Any panelist have anti-D role? No. Okay. So at present, of course, the anti-D is not available, but we have used that. But because major concern is there is a chance of fall in hemoglobin, it's not a good drug pre-operatively. But in emergency, you can use. At present, it's not available. But if you see this data, anti-IVIG a lot of more advantage over the anti-D in this group of patients. So, but if you have a long duration elective surgery, sometimes you can also look for using TPO inhibitors beforehand for 2 weeks before, so that you can achieve the target in this group of patients. So, I think coming back, continue to look at case number 1 again. She improved dramatically that episode and responded well to therapy because he responded well in the last time also with IVIG, and off treatment for almost 10 years. Patients now from 16 to 26 years old, maintain the platelet count more than 150. She had a RTA, road traffic accident, and operated major orthopedic surgery, and the pre-op platelet count is 187. So that time the hematology consultation was not sought. But on 4th operative day, she had a spike of fever and on antibiotics, and was started on antibiotics. And on day 5, she went to shock and developed acute renal failure, and oozing from various sides, including the central line sites. So at that moment, hematology consultation was received, and the hemoglobin showed hemoglobin 7.2 with platelet count 32,000. So here is the thought, what is the possible cause now? So question to Dr. Sunita, please. Okay, how should be the possible reasons now and why there will be post-operative thrombocytopenia in this setting?
Yes, sir. Actually, thrombocytopenia from anesthesia point of view for us, pre-operative, even intraoperative and post-operative, we are very much concerned because our plan of anesthesia also changes according to the like what are the previous levels of platelets before we induce the case. So it is extremely important for us. So there are various reasons that patient is having thrombocytopenia. May it be up to POD 4. It can be because of hemodilution, because of liberal use of maybe IV fluids, or
Yes.
if patient has received any blood components
Yeah.
or any massive blood transfusions, then there can be hemodilution which is causing thrombocytopenia. Or if platelet sequestration can occur because of splenomegaly. On say POD 4 or 5, because as you have said in this, there can be like consumption of platelets because of maybe hematoma or sepsis or infection, and that consumes lot of platelets, and that's why there is thrombocytopenia. There is one more reason we should always ask patient or take history, because sometimes there is marrow suppression because of drugs, various drugs patients are consuming, and most commonly a lot of antibiotics are given to the patient, and that causes bone marrow suppression. And even we see heparin-induced thrombocytopenia in almost 2.5% patients. We can see this HIT, and it is seen that when we start patients on heparin, almost after 5 to 10 days, there is this fall is seen in platelet counts.
Okay. So
We see many, all these anti-cancer agents also can cause thrombocytopenia, and even routinely used drugs like ranitidine. Nowadays we don't use, but previously we used to use ranitidine, haloperidol, ampicillin. All these drugs also can cause thrombocytopenia.
this patient have infections and also
Infections,
thrombocytopenias.
And in obstetric patients, like when we see our severely pre-eclamptic patients or early help patient, early help syndrome, in that there is thrombocytopenia because lot of platelets are destructed, and this is destructive cause to cause thrombocytopenia.
So it's most likely maybe septic induced or maybe drug induced or maybe DIC because
Yes.
because he had infections and subsequently
Even
developed.
quality
Okay.
of platelet is not good.
Okay. So this patients again, if you see the DIC international ISSTS scoring is matching with that. We have platelet count is less and PTA, PTT both are prolonged. D-dimer also prolonged, fibrinogens. Based on these findings, DIC score is 6 and creatinine is also high. So blood culture showing positive epilepsy loss. So diagnosis of post-trip sepsis with DIC was made. So now the question is how to manage subsequently to Dr. Anita, please. How do this patient to be managed and any specific treatment DIC apart from transfusion support in these group of patients?
Thank you, sir. Thank you, ISHBT, and thank you, IMA, for the opportunity. Now, clearly, we have a patient who is a post-operative patient, day 4. Patient is in shock. Patient is having renal failure, and patient is bleeding actively. And this patient has a DIC score of 6. So he has an overt DIC. So in management, the principles of management, firstly, in DIC we have to treat the cause of DIC, and in this patient it can be sepsis because it is day 4, and we have a blood culture showing the organism. So we start him on higher antibiotics to treat the sepsis. And we also need to do general management in this patient because the patient is very sick, the patient is hypotensive. So you need aggressive fluid management in this patient, and aggressive fluid management with maybe patient might need vasopressor because he is hypotensive. And other management like the maintenance of temperature is very important because you must avoid the triad of hypothermia, the coagulopathy and metabolic acidosis because that is supposed to be the lethal triad. So this general management, and specifically for transfusion for this patient will need platelets transfusion, the FFPs. Now, this transfusion guidelines are not depending on your lab parameters. The lab parameters should not dictate whether you want to transfuse, but you should see whether the patient is actively bleeding, one thing, or the patient is going to need a surgical intervention during which the patient might bleed. So this patient is having hemoperitoneum, he is bleeding from the sides. So he is actively bleeding and he will need a platelet transfusion, maybe SDPs, so that to maintain his platelet count around say 50,000. And the fresh frozen plasma to give him the coagulation factors. And a cryoprecipitate maybe if the fibrinogen levels are low, but his fibrinogen levels are okay. And of course the RBCs, the packed cells, to maintain the hematocrit around 9. So this will be the...
So apart from transfusion, any role of any heparin normally used in DICs or in any...
yes, if actually in the DIC, if it is more towards the thrombosis, if it is going more towards the thromboembolic episodes, because this patient is in ARF, so it is possible that he is having thromboembolic episodes and that is why he is having ARF. So in that, because there is a role of heparin to cause anticoagulation to stop the further thrombosis. So there is a role of unfractionated heparin in 10 micrograms per kg. So infusion is preferred because you can stop the infusion anytime and it has a very short half-life. So heparin infusion is indicated.
Okay, so transfusion support is the major concern of the DICs. Apart from heparin has been tried, antithrombin concentrate also used, but there is not much of significant role in to reduce the mortality in these such group of patients. So our patients again, he had received antibiotics and also FFP, PRPs and subsequently antibiotics, and he had a line infection subsequently removed, and he improved this renal failure part and improved for the renal part. So I think this part will come to the case number 2. This case 2 is a 56-year-old man. It's known case of lower limb DVT, unprovoked DVT, and he has been warfarin for last 8 months with a stable INR. He was admitted to orthopedics department for hip replacement therapy operations. And CBC is normal and PT is 32 seconds, INR is 2.8. So hematology consultations when before surgery for clearance and management of perioperative anticoagulations. So now the questions to CTVA surgeons, Dr. Avya Singh Walia. What are the points we should consider before planning this type of patients for any surgery, patients on oral anticoagulations? And what are the risk of thrombosis or risk of bleeding in patients on oral anticoagulation patients?
Good evening, everyone. Thank you for inviting me to moderate this session. Sir, the question is very simple. We have to assess the type of risk for the procedure. Now, there are different procedures that we have for surgery. In this particular case, it is total hip replacement that we are looking for. But if there are small surgeries, they may not have so much of bleeding post-op. Risk of thrombosis, recurrence of underlying disorder due to procedure. That is what we're looking at. If there is a previous medical history or a bleeding history, patient has been having any other co-illnesses, in that particular scenario, it becomes a risk. Procedural bit risky, as we can see, small surgeries like cataract, dental, pacemaker implantations, all small surgeries. In this particular scenario, there is not much of procedural bleeding risk. So in that particular scenario, if we see the INR was 2.8, so even a little bit higher, maybe around 2 or 1.5, not much of a risk we can look for. But if you are having low risk surgeries where you expect some amount of bleeding, in that scenario, we need to control. We have to stop warfarin and we go in for low molecular weights. But if high risk surgery like THR, in such scenarios, I would like to withhold warfarin.
Yes.
Take them on LMWH, pre-surgery, 24 hours before, stop the LMWH, do the surgery, and immediately go in for restarting LMWH for this patient. Certain cases, I would avoid or delay surgeries. If suppose patient has a recent episode of thromboembolism, if patient is a post-implant, we have a cardiac surgery done, there is an implant in the heart, valve is there. If the patient has got a recent cerebrovascular accident or a stent. In these scenarios, we would delay this elective surgery and do not do this surgery. Try to convince the orthopedic surgeon, wait for some time and do it.
Excellent.
Now coming to the second part of your question is the risk of thrombosis. What is the chance that we can have? So as you can see that the lower grade where you may have, if suppose this patient has a past history of DVT, recurrent DVT now on warfarin, in that scenario, if the VT was 12 months back, no further risk, just go ahead, stop the warfarin, put on LMWH, go with the routine risk. There should be no problem. But if the patient has had a VT in this 3 to 12 months, then there is a moderate risk of recurrent thrombosis in this patient post-surgical. And as you can see, if the patient has got concurrent cancer, in that particular scenario also there is a problem. But in a high risk where if the patient has recently got a VTE, as I said earlier, we should defer surgeries in scenarios. And if we have a documented evidence of protein C, S deficiency, I would really not push this patient for a planned surgery right away.
So it is always a balance between the bleeding and thrombotic risk.
Absolutely, absolutely.
Okay, so fine. So next question comes to our mind, if it's on warfarin and plan for surgery, so is it necessary to hold oral anticoagulants? And as Dr. Wale said, and if yes, how many days? And if there is bridging necessary with the warfarin, and what happens to dual and with newer anticoagulants? Dr. Vinod, please.
Thank you, Dr. Mahapatra, and I wish to thank the organizers for calling me and giving me the opportunity. In fact, when Dr. Kalantri called, he said, we may ask you a question on SCA. I said, sudden cardiac arrest, I can speak for hours, I don't have to prepare. He said, no, SCA means sickle cell anemia. I said, oh my God, I'll have to really go through it. Anyhow, friends, it's very often that just to complete what my learned friend had also mentioned, that whenever you have put a stent and say you have got a life-threatening emergency, you have to operate. We always say that you have to postpone the surgery. But in case you cannot postpone the surgery, the guidelines have changed further. Nowadays, even we have got IV cangrelor, which can be continued just up to surgery. Go ahead with the surgery, stop cangrelor, the effect goes away, and then immediately post-surgery you may restart it and then start with the routine antiplatelets. So now, when we are talking of surgery in a DVT, there is always a balance between bleeding and thrombotic risk, which is there. And what we mean by interruption, how do we define? What is the risk of the surgery being done? What is the type of anticoagulant we have been giving, its half-life? Most important is the renal function and the thrombotic risk. And of course, we know that not all patients may require, and we have protocol. See, when we consider holding of anticoagulation, see, we can never say that you have no risk of bleeding. It may be a normal or minimal risk of bleeding in which you have to consider 2 to 3 times the half-life of the anticoagulant which you have been giving. And we should aim for a mild reduction in the anticoagulant which should be to the range of 12 to 25%. You cannot measure that. If there is a high risk of bleeding, then it should be a longer period of gap, 4 to 5 times the half-life till the surgery starts, and then the residual effect at the surgery should be just 3 to 6%. And most of these, there is also another factor is the creatinine clearance. If your creatinine clearance is more than 50, then there is a low bleeding risk, you may stop for 2 days. And if there is a high bleeding risk, stop for 4 days. And if it is impaired, then it is usually 6 days. If you ask me what about more than 6 days, then the effect goes away. In fact, there is a paradoxical hypercoagulable state which may lead further to increased propensity to thrombosis. So that is what is important. When you talk about bridging therapy, you see, this is what I was seeing all this, that what does bridge mean? That you are replacing a drug which was having a long anticoagulant with a drug which has got a short period of anticoagulation. And that means most of the time it is warfarin or other directly acting. And this was the assumption that if you do a bridging, the risk of thrombosis would reduce. And all these meta-analysis which have been mentioned, it shows that there is actually no a difference whether you give the bridge or you do not give the bridge, then why are we discussing all this? No, just go back, sir. And but it just you go through this. These were all publications in circulation in 2012, and the NOACs were not there. So now the scenario has changed, and we have to consider bridging. When do you consider bridging? By and large, to a cardiologist, there would be next slide. I would say 3 scenarios of venous thromboembolism, where if a patient has had thromboembolism within 3 months, he is a high risk. If he is a very high risk, that means even if, in spite of giving an adequate anticoagulation, normally our current PT INR, which we read old books like Grunwald, for prosthetic valve used to be 4 to 4.5. It's all given up. Now it is 2 to 3 most of the time. Where in spite of having an INR of 2 to 3, you still have an event, then you raise the target INR to 3.5. That means he is a high risk. Why these values have come down? One is because of our knowledge, and second is we are having better low profile cardiac valves, better type of implants, better type of stents. So venous thromboembolism is one thing. Other is atrial fibrillation. Those who have had a previous stroke in the last 3 months, but even if it is more than 3 months, these are the ones who are high risk, so you have to consider bridging. And these are the 4 usual subsets. Congestive cardiac failure, I may further subdivide into heart failure with reduced ejection fraction, higher risk, heart failure with preserved ejection fraction, still there is a risk. And if there is uncontrolled hypertension, diabetes mellitus, and age more than 75 years, but in our Indian subsect more than 60 years, again would mean a risk. And if there are mechanical valves, because now the valves have also become better and even low profile. So, what do you mean when you are talking about bridging with warfarin? See, if there is a low bleeding risk and high thrombotic, please continue warfarin. Please continue the bridging process. But if you are, why you have to withhold? And that is, you don't have to give a bridging, because if there is a very high risk of bleeding, you know is going to be, but the risk of thrombosis is very low, then you have to take a decision, but make it an informed consent. Discuss with the patient, the relatives, and your surgeon, and then you can withhold. And where is bridging utmost needed? When there is a high risk of bleeding and there is a high risk of thrombosis. But again, it is very important here, like the chart will tell you that you stop warfarin or similar vitamin K antagonist 5 days and start after 2 days. And once you have stopped 5 days before, you keep checking the INR. If your INR comes to less than 2, then start LMWX, low molecular weight heparin, usually enoxaparin, and stop 1 day before, and you may start after 1 to 2 days. And still, other would be a continuous infusion of heparin, and you have to monitor with the clotting time more than 2 to 2.5 times the baseline. Stop just 6 hours before the procedure and restart after this. Very important in that previous bridging slide is, what is not often a doctor has to understand, that whenever I am giving these potent drugs which are anticoag, should there be a bleeding, what do I know about how to stop? I should have antidotes. For example, in Pradaxa, we have got idarucimab, and if there is warfarin excess, you should know that this prothrombin complex should be given something like 100 units. We depend on our hematologists, frankly, and FFB. Dicolamide is also being used nowadays. For that, you have to give factor 10A concentrate and FFB. And Dindivan was a drug which was never not being used much. And more important as cardiologists, if you know that this person is going to have trouble, then think of non-pharmacological, a temporary IVC filter. I have implanted many a times left atrial occlusion devices and PFO closure devices. And these are about the newer anticoagulant, NOACs as we call them. And you have to still consider bridging if the risk is of high thrombotic risk, and if there is associated renal failure, and you should restart usually after 1 to 2 days if there is a low risk or high risk of bleeding, and sometimes even start with high dose. So, I mean, these are broad outlines, but then, we require much more to it. Thank you, I suppose.
Okay,
Any
so
question?
we have, I think, not much of time, so I think last question, so what about the antiplatelet therapy? If patient is on aspirin or any antiplatelet therapy before surgery, what is your plan normally, Dr. Nilesh? Or Dr. anybody, any panelist?
Regarding antiplatelet, you had mentioned, sir?
Fine.
Yes. See, there are most of the time we have got these three prasugrel, which takes a longer time. If you are having prasugrel, you have to stop 7 days. If it is clopidogrel, usually 5 days. And the best would be ticagrelor, which would be around 3 to 4 days. Ticagrelor has got an advantage, which you use more often, because it is a reversible inhibitor of platelets. Whereas once you have given clopidogrel and or prasugrel, then for that platelets lifetime, it remains blocked.
Okay. I think
Dr. Walia would like to add.
anything? Yeah, aspirin. Exactly, so.
With giving aspirin and they're trained to handle it. So I think there's no problem with aspirin at all. So the initial myth was to stop aspirin. For cardiac surgery as well, we used to stop for 5 days, but of late we have been operating very comfortably
depending on
with
surgery.
aspirin. So no issues on that.
Okay, I think we can stop here. I think you have time. I think if you want to do, we can stop here, okay? I think we can stop here. Thank you. Thank you very much.
Time.
Thank you all panelists for the quick time. Thank you.